this presentation where I show you a lot of topics that I'm not going to cover today in the lack of time, but we will go into, at first, I will tell you about what is epidermolysis bullosa, what are the pathologies associated with that, a little bit about the diagnostics part, and then I will go into how it is and what it is to live with EB and what has to be done to manage the daily routines when living with this disease. You will see some graphics that were done by Deborah International, which are called the EB infographics, which you can find then also on a link that I will provide you in the end. And every time you see this yellow rectangle pop up, this means that these are useful tools or useful literature for you to use in the future when you do diagnostics or treatment or care for the patients. Everything that is surrounded by this rectangle, you will find a link in the end. Oh, let me check whether this works out now. No. Sorry that you can't see me, but again, the most important is the content of the slides and not me and myself. So let's get started with an introduction into epidermolysis bullosa. Basically, the name of the disease, as with many diseases, already tells you what the disease is about. So it is called after the part of the skin that is most affected, which is the epidermis, so the outer skin. Then the word lysis is in there, which means basically a breakdown of a structure. And the breakdown of the outer skin leads to a blister, which is in Latin called a bollosa. So basically, the term epidermolysis bullosa tells you it's the breakdown of the outer skin, which leads to blisters or wounds. Epidermolysis bullosa is a rare or orphan disease, which means in a general population, only 1 in 17,000 live birth is affected, which makes it also hard to find often people who have the expertise in it, because if you don't see it that very often, you cannot build up your expertise on it. So it is very important for everyone, for us also, to share our knowledge with everyone who is interested and who might have to care for patients with EB. It is genetically induced and therefore hereditary. And the thing is that a lot of the parents don't know that they are carriers because they're asymptomatic, because only one allele of them is affected. And then if two parents have a baby where they inherit both affected alleles to the baby, then the baby will have epidermolysis bullosa, and I will go into the genetics just very little in my next slide. It can affect everyone. There is no bias towards gender or towards ethnic groups. So it is equally distributed throughout all populations. And as with every genetic disease, it is not contagious. Something we have to make the population often aware of, that any genetic disease can only be transmitted hereditary, but not by simple touch or any virus that can be transmitted via sneezing or something. And unfortunately, as of now, there is no cure for EB. There are symptomatic treatments for a lot of aspects of this disease, but a causal cure is not available at the moment. A lot of research is going on also into gene therapy with the new methods like CRISPR-Cas that can be used to repair gene mutations, but until now we're still a way ahead, or a long way ahead to this cure that we hopefully will get in the future. So, as I already said, EB is genetically induced and clinically very heterogeneous. I will have a slide later where I again make a point that every patient is different. Every patient, although they might have the same mutation underlying, there are a lot of epigenetic factors which we don't yet understand entirely, which also contribute to the clinical picture that we see in our patients. There are 4 hereditary forms, which are EB simplex, junctional EB, dystrophic EB, and the Kindler syndrome, and also one autoimmune form, which can arise later in life, which is called EB acquisita, which is caused by autoantibodies directed against proteins in the skin. But I will not go into the autoimmune forms today. I will mainly focus or only focus on the 4 hereditary forms. As of now known, there are 23 genes involved that can be mutated and then lead to any form of the 4 genetically induced forms of epidermolysis bullosa. As already mentioned before, the clinical picture is shown by the formation of blisters and erosions. And this can either be following minor trauma, which means a simple falling down on the floor or a rub from a too tight jean, or can also rise spontaneously. There are a lot of complications which are mainly affecting the severe forms of epidermolysis bullosa, and those are, amongst others, but not limited to, the stenosis of the respiratory or gastrointestinal tract, which mainly have to be corrected surgically. There's also enemal hypoplasia, and in later life, for these patients, and mainly for severe forms, there's also an aggressive form of cancer called squamous cell carcinoma, which is a main complication for the patients. Worldwide, around 500,000 people are affected with different forms of EB. I'm sorry that this is a little blurry, but it gives you an idea how complex the skin structures that hold our skin together are. And everything you see here are certain proteins that can be mutated, where their sequence can be mutated, which leads then in turn to a disruption of this very, very complex system. And as you can imagine, as you can see here, all of these structures anchor to another structure and to another form, another protein in the skin. And if one of these anchors is disrupted because of a mutation, and this mutation then leads to either the entire missing of a protein, so of a structure in this complex system, or an altered formation of this protein, this whole system cannot work properly. So to make this a little easier, I have made a small slide about how you can imagine this works. So you have here the epidermis and here the dermis. So this is the upper layer of the skin and this is the lower layer of the skin. And very simplified, you have proteins that anchor those 2 layers together. So you have proteins that coming from top, proteins that come from the bottom, and those interlink. And when you apply shear forces on the skin, these anchor structures keep those 2 layers of skin attached to each other and no harm done. The problem is, if you have a mutation in a gene sequence, what happens is something like this. So either you have a total lack of a protein, it can be either the upper or the lower part, or you have a mutated protein which looks different than the so-called wild type form. And as you can see here already, this part of this mutated protein lacks this anchor portion, and then can therefore, as you will see now, not really fulfill its function. And if you apply shear forces, the upper and the lower part of the skin will separate, and this leads then to a wound or blister formation. So this is basically the background of how these wounds arise, and this can also happen already if you imagine you turn yourself over at night while you're sleeping. This also applies shear forces to the skin, and then these 2 layers, because of the mutated protein, cannot stick together and blisters and wounds arise. As I said before, and this is something that is really important if you see patients or if you care for EB patients, every patient is different. although they might have the same mutation or the same layer where their blisters arise, every patient perceives pain differently, itch pain differently. Every patient has a different social economic background. Every patient has different care that he can get back to. So every patient needs an individualized disease management and care program. There is a certain type of so-called genotype-phenotype correlation, which means there are certain mutations that we know that have a severe disease outcome than others. But still, there are, as I've said before, a lot of epigenetic factors that we don't know yet. Also, psychological factors, environmental factors that leads to disease severity and disease progression. And depending, usually the classification of the four main forms, which are simplex, junctional, dystrophic, and Kindler EB, are parted depending on where the blister arises. So as you can see here, this is the epidermis, and in gray the dermis, and in between the lamina densa, lamina lucida. And depending on where the blister arises, you can already classify usually the subtype of EB that you see. So if it is mainly, or if the blister arises in the epidermis, you have, for example, epidermolysis bullosa simplex. If it can affect all the layers of the skin, it is usually Kindler. And if the blister arises within the dermis, it is dystrophic EB. So how do you then, if you see a patient, how do you define which type of EB does the patient actually have, and why is this so important? So diagnostics in EB, as in any other disease, is utterly important for to be certain that it is what you think it is, because there are a lot of other causes that can lead to the same clinical subtype. For example, autoantibodies of other causes that can also lead to blisters in the skin. And you need to be sure, in order to be able to treat it sufficiently, that it really is epidermolysis bullosa. Also, when you have the diagnosis, you can prepare the patients and caregivers for disease progression. Although not every disease progression is the same, a lot of co-pathologies that come with this disease are foreseeable. And because a lot of them are foreseeable and need to be detected early, you have to monitor possible co-pathologies closely. And also for this, you need to know which type of epidermolysis bullosa you're dealing with to know for what to look. And how can this be done? Of course, the first thing you will always do is a clinical diagnosis. You're going to make an anamnese. You're going to exclude other causes. You can also do histology, antigen mapping, and mutation analysis. So the gold standard for diagnostics in epidermolysis bullosa is mutation analysis, where you take blood, or nowadays also even buccal cells, from a simple swab. You isolate the DNA and do a sequencing on it. And with this, you clearly see where the mutation is located, and you definitely can say which subtype it is, because with every mutation, a subtype and even a subtype is associated. We know that antigen map or mutation analysis is not available in all countries. That's why antigen mapping is also a good way to localize and to define the subtype of EB that the patient is suffering from. And this is done by taking a skin sample, so a punch biopsy, doing ultra thin slices, and then stain the skin sections with antibodies colored to fluorochrome. And what you basically do there is you have a look whether a certain protein is present or not. So as you can see here, For example, this is healthy skin where collagen 7 is present, and it gives you a nicely yellow, nicely light green stain. Whereas this is a patient sample where you should see a staining here in this lining, where you can see clearly that it is absent, which already tells you that this patient is suffering from a certain type of epidermolysis bullosa. So you're going to do this for a lot of different proteins, and then you see which ones are either present or absent, or where their amount is reduced, which is also possible. Clinical evaluation of the presentation of the patient can be supplemented with histology, so simple H&E staining, although this sometimes might give you a slight hint of what the subtype can be, but often is not really sufficient to give a clear answer. For physicians who are not already that skilled and not already have seen a lot of patients, a group from India, Abu Dhabi, and the UK developed a so-called diagnostic matrix for epidermolysis bullosa, which can help you to identify certain subtypes, certain bigger forms of epidermolysis bullosa in your patient, so that you then also might know which proteins to look like in antigen mapping, or narrow down which mutations you have to look in mutation analysis. And this is something I want to show you a little bit now, because I think it is a very useful tool if you're not already that skilled in clinically diagnosing epidermolysis bullosa patients. So this can give you a very good support in that. And this diagnostic matrix is an Excel-based questionnaire. So you don't have to have a lot of resources. You don't have to have a specialized program. It basically runs on almost every computer, and you can get in very easily. The link will be provided at the end of the presentation. And what it does, it narrows down the clinical diagnosis to one of those, or one or two of those subforms that you see here. And this is done by assessing 19 clinical features. And those are, amongst others, for example, the presence or absence of milia, which is very characteristic for some types of EB, and the absence very characteristic for other types of EB. It also asks about whether there is a microstomia in those patients. It also asks whether there are already signs of syndactyly in those patients. This is something that is mainly associated with very severe forms and not with milder forms. It also asks about scarring in the patient. How extensive is this scarring? And when you answer those 19 questions, what you get is a calculation like this. So every aspect that was asked is assigned a certain value, and those subforms with the highest value are most probable to be the subtypes of your patient. So I did this with one of my patients, and what it showed me that it very probable is either a Kindler syndrome or EBS generalized severe. And with that, you can then go on and do deeper analysis and also go on with your care regime. So after you have the diagnosis, of course, what comes up is all the care questions associated with this diagnostics. So there are a lot of different issues that have to be dealt with when caring for patients with EB. But I tried to summarize at least some of them, and parted them for milder forms and more severe forms. And the first thing that you have to think about is, how is this disease going to progress over time? For mild forms, you mainly have the issue of scarring after blistering, also the issue of hypo or hyperpigmentation, mainly on those spots where the blistering occurred, and also alopecia, so the loss of hair at certain parts of the body. With severe forms, of course, there are more severe degrees, disease progressions. Like in very severe forms, you have cancer coming up, as I told before. You have so-called pseudosyndactyly, which is a stiffening and a growing to get a fusion of fingers and toes, which makes it hard to move them and to stretch them, which of course is a major impact in the daily life of those patients. And also you might in later, very later progression, you might have to deal with organ failure. With knowing what disease progression can come up, you are asking yourself, of course, what are the care issues that arise through that? In mild forms, it's mainly sufficient skin care. So this might be enough in a lot of mild forms. And this will also then milden this disease progressions. For severe forms, you will have to think about proper wound management, pain and itch treatments, which are very important in very severe forms. You might think about physical therapy and treatment of all those co-pathologies that can come up. And what are the treatment options for those? In mild forms, again, usually it is enough to have creams to improve wound healing, maybe have antihistamines for itch treatment, and have wound cleaning agents. And then in these mild forms, usually the skin has the ability to very well heal itself. In severe forms, creams to improve wound healing are mainly daily accessories. Pain and itch medication have to be very carefully taken. You have to think about proper bandaging material, something that in mild forms usually is not that big a deal and not that big an issue. A lot of patients even prefer to not use bandages at all in mild forms, which is usually not doable in severe forms. And you also have to think about maybe there are surgical interventions coming up, like I told you before, the widening of the esophagus, for example, that can come up. At the moment, there is a lot of research going on into new and advanced therapies, and they are currently tested, but they're still way ahead of us until those reach market authorization and therefore are available for a wider patient population. There are, for example, small molecules that enhance wound healing even better than creams that we have now, because they target EB specific problems, for example. Then there's also gene therapy coming up, and a lot of this is going to make a big improvement for the life of our patients in the future. But again, as of now, those treatments are not available. So this is the slide that only has some of the issues that EB patients face in their daily routine. A lot of this, again, is mainly for severe forms important. For example, dental care in very mild forms is basically no problem. They have teeth as a healthy individual, so it's not a problem for them. But for example, going to kindergarten, going to school, or having to do work is an issue for all of the forms. Whereas release surgery is only an issue for severe forms. But you see how diverse the care and the treatment for our EB patients is. And what I will go into today is only pain and itch management, wound management, and nutrition. And I will start with wound management. And first, it is very important to assess the skin and all the wounds regularly, and not just regularly by a physician or by a caretaker, but also by the patients themselves. They should always have a look at whether those wounds that they have, whether new wounds arise, or whether wounds heal not the way they usually do. So they have to have a very good look at it. And something that goes in line with what I told before. Management must be tailored to suit both the type of EB and specific characteristics of the wound. Every patient is different, so there is no regimen that you can apply to every junctional EB patient. There is no regimen that you can apply to every EB simplex patient. Every patient is different and needs to have a very tailored care regimen for themselves. And people that live with EB and their carers, they see this disease every day. They have to live with this disease every day. So a physician, although they are for sure very well trained in all the backgrounds the disease has and all the underlying causes and all the disease progression that might come up, the daily life of these patients is EB. So they are also an expert in this disease and in the daily life and in the managing of this condition in their daily life. So for wound management, one of the most important things, and especially in severe cases, is the dressing change. Something that patients in later in life get very accustomed to and might be a very new issue for parents that give birth to an EB child. So a dressing change should usually follow one of this regimen, which is first, you always have to make sure that all the equipment you use and also your hands and the surface you do the dressing change on are clean. Because one of the major complications is wound infections. And you can minimize the risk of wound infections if you always have clean equipment, clean surfaces, clean hands when doing dressing change. Then, if you do the dressing change, it is very important to carefully remove bandages. Do not rip them off like a bandage. It can worsen the condition of the skin. And something that a lot of patients like to do is that they remove the bandages in warm water. This is in warm water, the bandages usually swim off and they are very easily removed. So what you can do is you prepare a bath with lukewarm water. You can also add salt or bleach, which is an additional care for the skin and for the wounds. So it is always recommended to either use salt or bleach. And then you can soak either the limbs or the whole body in this warm water, and then the bandages will come off very easily. If you use bleach, it is very important that afterwards you clean the whole body. What you usually should not do is that you directly pour water on the skin, because a lot of patients feel that this is painful for them. So what you can do is you soak a sponge and then very carefully rinse the water over the patient's skin. And bathing can be done daily, every day, whatever the patient feels is suited for them. Very important, if you remove the bandages in warm water, is that you then dry the skin and the wounds, because a humid milieu is basically like a breeding chamber for microbes, and microbes then impair wound healing. So it is always important that you dry the skin very gently. Again, shear forces damage the skin of EB patients, so you have to gently tap the skin to dry the skin and the wounds, and don't rub and don't rub the skin. Also important is that you lance blisters. Blisters are not self-limiting in EB. So if you have a blister and you leave it, it will get bigger and bigger and bigger, and therefore hurt more, and there will arise a bigger wound. So it is important to lance blisters. Also here, have clean equipment that you use. And then apply either wound healing creams or creams for skin care. What you can do is you either apply those creams directly onto the wound, but a lot of patients feel that this uncomfortable. So what you can do is you apply those care products, those creams or those ointments, to the dressing material, and then add the dressing material to the wound. A lot of patients prefer this way. For very moist wounds, you can use creams that contain zinc, because this dries out the wound a little and helps the wound healing. And for infected wounds, you should use antiseptic creams or antiseptic dressings, because infected wounds don't heal properly. And then, of course, you can also apply moisturizer to intact and dry skin. Important, never apply moisturizer to wounds. Only on the surrounding skin and a non-affected skin, but not on wounds. And then in our experience, the best way to do the dressing is a so-called three-step wound dressing. And this contains of first a direct wound covering, then a padding and a fixation. The direct wound covering can either be a contact layer, as I said before, where you apply the creams or the ointments on that you want to use and then apply directly to the wound. These can either be simple contact layers or meshes, or can be thicker foam coverings if you want to. If you already use thicker foam coverings that already give you a protections from outside forces, you will not need to have a soft padding over the wound again. And this soft padding protects you from outside forces and also absorbs wound exudates, because of a lot of the wounds are going to leak, and so you have to have something that soaks up the wound exudates. And you want to fix those wound dressings now on the patient. And what you of course cannot do is put on a plaster or anything that is adherent to the skin. So what you can do is you either use for so-called cohesive elastic bandages or bandaging tubes. So in our experience, those bandaging tubes work very well. One thing that you have to be aware of if you use cohesive elastic bandages is that they stiffen back. So if you apply them very loosely, they will get stronger, so that the friction will get stronger over time. Also, be aware that those fixations are loose. The more pressure you put on those fixations, the more friction you apply on the skin of the patients, which again might lead to damaging of the skin. After wound management, and if wound management is done correctly and in a thought of manner, you will also think of what bandaging material should I use. Of course, all bandaging materials and all wound dressing have to be non-adherent. Of course, it will damage otherwise the skin of the patients. The patient itself usually is the expert on what works for them best. So usually they should try out different bandaging materials and then decide for themselves what works for them and what works for their daily routine. If high-grade bandaging materials are not available, and this is sometimes the case because they're sometimes expensive and insurance does not cover it, there are some alternatives that can be used. For example, for direct dressing of the skin, you can use cling film or cigarette paper or banana leaves. Again, make sure that all those materials are clean if you use them, but you can apply ointments or creams to all of them directly and then cover the wounds with it, and have then also a covering or fixation also with cotton towels or bedding. Those can be reused, but they have to be washed very hot in order to get rid of microbes, and they can also be then hot ironed to get rid of microbes. So this is very important. If you reuse, for example, bedding or cotton towel, make sure that they are properly washed and properly cleaned if you reuse them. For moisturizer, also you can use substitutes, for example, olive oil. Olive oil is also known not just for moisturize the skin, but also known to be anti-inflammatory. So these are some substitutes you can use if high-grade bandaging materials are not available. This is something I wanted to show you because a lot of patients and especially parents with newborns find very interesting is how to cut the bandages. And there are different bandaging and cutting patterns that are available. Those are just some that work very well. So you have your bandaging material, you have your big sheets of covering material, and then you can cut them to best fit, for example, joints like here, the heel of the baby, so that there is still the possibility to move the joints and that is not hindering. Something that I also want to show you is a bandaging technique that is used for prevention or delay of the so-called pseudosyndactyles that I've shown you before, which is the stiffening of the skin and the web of the fingers and the webbing of the skin over it, so that the patients then are not able to move their fingers anymore. And to prevent or to delay this, there is a specialized bandaging technique, which I hope works now. Yes.
So we want to wrap every single finger individually. And right here, put a bit of a pressure, but not too much pressure, because again, Destiny's skin is really, really soft. So once we wrap each individual finger, we go kind of like this, something like this, individual, and just pull a little bit. And again, I don't know if this is like the exact way they taught me. This was years ago when Destiny was really, really small. But this actually is really effective and it really works for us. And that's it. To see, spread your hand. So each finger is wrapped individually, and hopefully it keeps it from webbing at nighttime.
So this is, although she said she's not sure whether this is the right technique, it is a very good technique to prevent this webbing and stiffening of the fingers. And this highly increases the quality of life for those patients because they can handle a lot of things themselves then. So aside of wound management, one of the biggest issues for the patients is pain and itch. As you can imagine, open wounds and blisters hurt a lot. So there is in EB, there's once the chronic pain, like the wound pain, the blister pain, and also joint pain. But there it also is, as in every one of ours, is acute pain, like post-operative operative pain, a headache, a backache. Those acute pains are treated as in any other patient. But chronic pains, especially wound pain in severe forms, we have to give special attention to. So the first thing you want to do is minimize any trigger for pain. And this you do with wearing loose clothing. So a very tight jean will put friction on your skin, will damage your skin, and will worsen your condition. As said before, always use non-adhesive bandaging because this makes the dressing change much easier. Already also said remove bandages in warm water. Always treat infected wounds. Infected wounds hurt more, don't heal, so they stay longer. Again, the longer the wound, the longer the pain. So always treat infections. What there for what are also a lot of studies or evidence nowadays is that good nutrition also leads to better wound healing. So this is something I'm going to come to at the end of the presentation. So good nutrition is also important. Something I also want to emphasize is always prepare all the materials that you need for the dressing change before the dressing change, because this quickens the dressing change, and a skin or a wound that is open and exposed to cool air usually hurts more than a wound that is bandaged. So a lot of patients tell us that as soon as they open the wound and the wound is exposed, it hurts more. So the quicker the dressing change, the less pain. And also it is known that physical activity balances the hormone levels, which also is important for pain perception. If then those triggers are, and there is going in severe forms, there are some cases where you won't be able to get rid of those triggers for pain, you can use psychological coping. And for chronic pain, this mainly means cognitive behavioral therapy, which deals with how do I feel the pain? What do I let the pain do with me? So this is something where patients should get psychological advice in how to deal with this situation, with the thoughts that are coming up. Some patients also reported that hypnosis helped them a lot to deal with their pain. Relaxation training mainly focuses on breathing techniques, on imagination techniques that help you to cope. Distraction is especially important for example, for children during dressing change. And also one very important issue, especially during dressing change, is to maximize patient control, so that the patient says, okay, yeah, now you can remove the bandage, I am prepared for it, or says, I need a break, I need to focus again. And this is really something important, that the patient has control over what is done during the dressing change. If psychological coping does not help anymore, of course, there has to be medical treatment in order to cope with pain. The first go-to usually are non-steroidal anti-inflammatory drugs like ibuprofen, which is, as the name already said, anti-inflammatory. And pain and wound healing comes with inflammation, and inflammation is painful. So if you dampen the inflammation, you can also dampen the pain. Cannabinoids can also be used and are under investigation at the moment, how well they can help AB patients in coping with the pain. For acute pain, you still can use paracetamol, but be aware that paracetamol is not anti-inflammatory, so it will not help with wound pain. It will, of course, help with a headache or something, but it will not help with wound pain. Opioids is an issue. It's controversially discussed at the moment. The thing is that opioids have side effects like itching and constipation, which is already a problem with EB patients. So adding side effects of a treatment to that are already a problem for the EB patients might not be beneficial. And in very severe cases, you can also use topical anesthetics during, for example, dressing changes. Very important, never use topical anesthetics directly on open wounds, only on surrounding wound tissue, on surrounding skin tissue, but not on open wounds. With a lot of those drugs, you always have to be aware that epidermolysis bullosa is a chronic disease. So you have to be aware of long-term use side effects of all of those drug treatments that you might use. Importantly to mention is that salicylic acid, better known at least for us as aspirin, can increase the risk of bleeding. And with patients with a lot of open wounds, this might be not very feasible. It might be not the go-to drug to prescribe. All of this you can also find in the best practice guideline, which I will provide a link then at the end of the presentation. So with pain, also there comes itch, and itch is mainly caused by dry skin and healing wounds, and again, inflammation. Itch is very, very differently perceived by patients. So there are patients that don't have an issue with itch after all, and there are patients which say this is their main concern and their main impact on their daily life. One thing that also can contribute to itch, aside from the wounds, is anemia, which I will come to just on my last slide, or on the last slide. And again, here, the first you want to do is to minimize the triggers for itch. Sufficient hydration leads also to hydration of the skin, and dry skin itches more than hydrated skin. So keep the patients sufficiently hydrated. Also, try not to overheat the skin. I know, especially in southern countries, this might be very hard to do. And what you then can do is use cooling compresses. So, for example, make a black tea, for example, which is other beneficial components, and let the black tea cool, which is very important. Don't use hot black tea. Let the black tea cool. Soak some dressings in it and apply those on the skin. So those have a very good cooling effect, and cooling counteracts the itching sensation. For night, try to use allergy-free and light materials, also for clothing, which also again goes with do not overheat. So use light and loose clothing to get the skin the possibility to breathe and avoid sweating. Some patients also report that they have to change their dressing material because the itch comes from the dressing material. Also something you always have to keep in mind when you care for patients, that this might be an issue. Again, also for itch, there are psychological coping mechanisms that you can try. Relaxation training is one of the main things that you can do. It are, again, breathing techniques, it are imagination techniques that distract you from the itch and that let you cope with the itch. Especially in children, it was shown that the itch increases in the evening. So when they are agitated the whole day, the itch increases when they have to go to bed. So what you want to do is have a calming bedtime routine, really have the same routine every evening so that they can calm down before they go to bed and relax, which helps with the itch. Again, if these two mechanisms are not enough, there are medical treatments that you can do. Skin care for dry skin is always important. Something that is coming up in the last years is skin care products that contain urea, which helps to moisturize the skin. Against itch, of course, antihistamines can be used, and for really only for severe cases and only for short-term use, which is very important, only for short-term use, glucocorticosteroids, which can be used to cope with itch. The last thing I want to go to is nutrition, because it is also a very important topic in epidermolysis bullosa, because as I told you before, a good nutritional status improves wound healing. But because of this wound healing, a lot of patients have malnutrition, because wound healing is very energy consuming, and open wounds and blisters were also shown to release protein. So you have a protein loss in those open wounds. And one big problem in EB patients is also inadequate food intake, especially in severe forms, not in mild forms. Mild forms usually don't have an issue with nutrition and inadequate food intake, but severe forms have. So severe forms of EB have an increased demand of calories, proteins, minerals, and vitamins. This is something that is to be emphasized with the patients. And what you first should do is an individual nutrition counseling. Every patient, again, is different. Every patient has different needs. Every patient has different accesses to food supplies, to supplements, and so on. And specialized nutritional programs are mainly needed for severe cases and not for mild cases. It is very important that you emphasize for patient that an early proactive intervention is good to optimize the nutritional status. So be proactive, start early, and start with a balanced diet. This is the first thing. It's important for every one of us, but especially with such a chronic disease where you have an increased demand on minerals and vitamins, it is even more important. If there are a lot of blisters in the mouth and meals cannot be chewed, meals can be pureed. And if so, they also can be supplemented. You can supplement them with fats or with proteins by simply adding a tablespoon of olive oil, for example, or add cream to a soup. Also puree avocados in it. They are high in fat, for example. High in proteins are, for example, nuts. You can soak them in water, for example, overnight, and then mash them together with the meal that you want to provide. They add a nice taste to it, and they are high in protein. What can be used also for nutrition and for supplementation is baby food. Not just for babies, but also for adults. To supplement the normal meals, you can have baby food because they're often supplemented with minerals and are high in calories. But be aware that high in calories often means high in sugar, because of course it is a very good calories delivery, but high in sugar also is bad for teeth that might already be weakened due to the underlying condition of epidermolysis bullosa. So what is important is to have regular dental checkups for the patients. And again, here, the point of hydration. Hydration, good for the skin. Hydration is good for the whole gastrointestinal system. So hydration with water or unsweetened teas is very sufficient, very important. Of course, in very severe cases, the need for these high amounts of calories, vitamins, minerals might not be doable, or might not be intaken with a balanced diet. So what you can do is substitutions or supplements to give. A problem that a lot of our patients deal with is constipation. So what you can give them are supplements that are high in fiber. We have good experiences with the so-called OptiFiber. I don't know where this is, where you can get hold of this, or whether there are other brands that you can use, but use something with high fiber. If this does not work, you can also use laxatives in various forms, whatever the patient thinks it's suitable for him best. One of the biggest issues most severe forms have, and almost all patients with very severe forms suffer from, is anemia. And usually you're not able to balance the iron values in the blood by balanced diet. So what you have to do is either give oral or systemic iron substitution. But the problem with especially systemic iron substitution is that it leads to constipation. So you will have to find a balance between the treatment of the anemia and the treatment of constipation. Also, what can be supplemented is vitamins, and very important here are vitamins of the B group. What is lacking here is vitamin A, which is also important for the skin. Latest studies have shown that vitamin D is very, very important for wound healing. So you might want to substitute that. And also vitamin E is important for skin stability. And for protein deficiencies, of course, you can substitute your meals with protein powders that are available in, for example, supermarkets or drugstores. Often what physicians think that if a lot of a big proportion of your body is covered in wounds, it is comparable to burn patients. But be aware that nutritional recommendations for burn victims are usually mega doses that are only intended for very short-term use, because you supplement the body during the healing process of your burns and then you stop the treatment. Whereas epidermolysis bullosa is a chronic disease, and therefore you have to think about long-term use of those supplements. So extrapolating those nutritional recommendations for burn victims, you have to be careful with this because of these really, really high doses that can have then side effects if used long-term. Here is a recommendation on how often to monitor the blood status and the nutritional and inflammation status via the blood via lab tests. And the last slide I want to go into is something that a lot of young mothers that give birth to a child with EB have is, can I breastfeed my baby? And the answer is yes, you can. Although severe forms might develop blisters in the mouth cavity, on the tongue or on the lips, you still can do breastfeeding. We recommend that you use, for example, lanolin, which is wool oil, on the lips of the baby, on the cheeks of the baby, and on the nipple, to reduce the friction during sucking, which makes it much easier for the baby and reduces the friction on the skin and on the mucosa, so it is not that harmful for the skin. Also, what is always good for the mother then to seek lactation counseling, because the stress of giving birth to a child with EB and getting to know of this chronic disease might impair the milk production. So it's always good to seek lactation counseling and also get into the habit of how to breastfeed the baby. If either the mother does not produce milk or really breastfeeding is not possible with the baby, you can also do bottle feeding with specialized formulas. They are, I think, available in different brands, and they have high concentration of nutrients. And one thing I want to show you, because sometimes those sucker attachments, the babies have to suck very hard to get the milk out of the bottle. And again, here you can cover the nipple in lanolin. And something that I want to show you are specialized suckers. For example, those special need feeders by Medela, where we have very good experience with. They look like this, and what is special about them is that depending on how you hold the bottle, this advices facilitate a continuous flow of the milk, and the baby does not have to suck. It only has to swallow what rinses out in a continuous flow into his mouth. So this completely gets rid of the friction that happens when sucking on the nipple of the bottles. So this is something that I really that you really should be aware of for feeding the babies. Try to get hold of something like this special need feeder for the babies, because it really will help them to get their nutritions in and to get their food in. With this, I just want to show you the links of the useful tools and publications that I've shown you throughout the presentation. So I have here the diagnostics metrics that I've showed you. For your EB patients, very nicely summarized is the EB handbook that was done by our physicians team at the EB house. It is currently available in German, English, Italian, Spanish, and Chinese. You can download it here, and this is something that really summarizes what patients should be aware of in their daily life, and it is subdivided into different subforms and so on. Here you can find 2 videos on how to bandage fingers. On our EB Clinic website, you can find clinical practice guidelines, not just on pain management, the one that I've shown you, but also on oral health care, on cancer management, on foot care, and so on. Then you have the link to the clinical guideline for nutritional support. And I've also inserted the link to the special needs feeder that we have very good experiences with. Last but not least, if you are listening in as a healthcare professional, I would like to invite you to our EB Clinic program. This is a network of healthcare professionals working with EB, healthcare experts with EB, and this network will help you to connect with your colleagues. You can discuss certain cases, severe cases that you have with them. If you want to get a second opinion, you also can subscribe to our newsletter, where we will send out monthly information about the latest informations of the EB community. And if you are a patient or family or patient advocate that is listening in today, go to Deborah International and find out whether there is a patient advocate group or patient care group in your vicinity that can help you with dealing with this disease. And with this, I want to thank everyone who listened in today and was interested in this topic. And I think we have a question and answer session now.
Yeah.
And we have a presentation.
Yeah. So thank you so much, Dr. Sophie. It was a great, informative lecture, from the definition of the disease into the diagnostic tools, and the management was amazing. I mean, I really cannot describe how informative it was. So we will answer the questions later at the end of the session. We have our international medical director, Mr. Emilio Galia, will have around 10 minutes of just a small introduction of the technologies that Urgo Medical provides for some of these patients to help them in the skin management and wound care management. And then we can answer part of the questions, because we have around 50 questions. And these, what is the written questions? I myself have 6 or 7 questions extra, but maybe we can answer some of these questions now and keep later to answer by email. We can send later and share the answers with them. So, Mr. Emilio, the mic is yours. Welcome.
Thank you very much. Thank you very much, Dr. Sophie, for a very amazing presentation. I think all of us were glued to our screens, listening to you, to the great information. I only have a few slides. I will take about 10 minutes or so. Talking about what the international best practice guidelines do suggest for these very special children and patients. Obviously, as was highlighted, we definitely need to take care of further injury. Handle with care cannot be overemphasized with these patients. And I saw some questions in the question bank about blister management, and Dr. Kusmura already hinted about it, that we need to lens these blisters. Some patients maybe would suggest to cut a bigger hole there, but lensing should usually be enough. The roofing is not suggested in these patients because it will make it even more painful. So according to the international best practice guidelines, which you can find online to download, this is the suggestion for blisters, that we lancet them. We always be careful to not introduce any serious microorganisms there. Other questions I saw in the question bank is, what type of dressings should we use? And according to the guidelines that I hinted to before, one of the technologies that they suggest is the lipidocolloid technology, more known as Urgotul by Urgo Medical. It's a wound contact layer, which provides moisture wound healing environment. Can be used as an alternative definitely for soft silicone, especially if there is presence of overgranulation. There is both a contact layer, but there is also a foam dressing without a border, which will still give you the benefits. If there is infection, there is the Urgotul AG, and we will show you very slightly what the technology is. What is very important and what is highlighted and what was already hinted is that staff or even carers taking care of these patients needs to be very well aware of what they're doing in order not to cause any further harm for these patients. So the Urgotul range is the technology lipidocolloid, which I'll show you very briefly what it is. It's being trialed in many patients. In a publication by White et al. In 2015, it was suggested that it was trialed in over 54,000 patients. I think we have reached around 59,000 patients now with all the aspects of the TLC technology. So what is this TLC technology? Tender loving care? Probably, but it's technology lipidocolloid. It's got the lipophilic particles and the CMC particles. And through in vitro studies, it was shows that the slight gelification of this dressing will create a moist wound environment and stimulate proliferation of fibroblast, collagen, and hydrochloric acid. So it is not just a non-adherent dressing, it also promotes wound healing, which is important for all the patients, but obviously for EB patients, we need to close these wounds as soon as possible. And through an in vivo trial that showed atraumatic and pain-free removal as well, which definitely is a must for our EP patients. So the Urgotul contact layer, as we said, enables pain-free removal. It is flexible, so it is good to use even on fingers, elbows, etc. Keeps its coating integrity over time, so when you are removing the dressing, it's easy to remove it and will not adhere there. Can be cut, can also be used if you have the shallow cavities. The other dressing is the Urgotul AG Silver, which is very, very similar to Urgotul because it's, again, the TLC technology. However, now we have added to it the silver sulfate, so you can use the Urgotul in non-infected wounds and the Urgotul AG when you have an infected wound or wounds which are prone to wound infection as well. One interesting thing is that in the edition of the journal Wound Care a few years ago, there was a study that was particular in EB patients using the Urgotul dressing. So what they did here, they wanted to see the acceptance and the tolerance, but also the efficacy of the Urgotul dressing. Does it do what it says on the box, basically, when it comes to EB skin lesions? It was an open label trial, obviously, because both the patient and the doctors knew what the dressings was. 20 patients, which people might think it's not a big number, but when we consider the amount of EB patients, 20 is quite a big number there. They were selected from the register of EB patients. The lesions were either being dressed previously or newly diagnosed wounds, and they are dressed for a maximum of 4 weeks, which was the duration of the study. So if we look at the first results, what is very important, obviously, is wound healing. We have 19 out of the 20 patients that healed between 8 and 9 days. The one wound which did not heal, it had 50% wound area reduction, which was actually in line what was before when she was using other dressings. So it fared quite well on the wound area reduction and the wound healing. Most of the patients said that they had a better improvement in their quality of life. The dressing was considered as easy or very easy in almost all of the patients. Most of the patients consider their dressing taking less time or taking similar time, which is very important. And I will show you an example of a patient at the end and tell you what time is sometimes for these EB patients. And importantly as well, 98% was considered as easy or very easy for the dressing removal. As we see here, they didn't consider the dressing application. They considered the dressing removal because this is what is very important for these patients. Again, talking about pain, so most of the patients did not require any analgesia, and the remaining only required something like a paracetamol. And most of them stated that the dressing that was being used now, which is the Urgotul, was less painful and definitely less stressful than the other types of dressings that were being used. So basically the conclusion we'll see that in the study that was done in particular EB patients, and this is probably why Urgotul is included in the international best practice guidelines, is that it heals the wound, which is very important because most of the non-adherent dressings do not provide a milieu of wound healing, but also it was gentle on the patient and good on the patient. We will see a very short video, it is just 1 minute, on how the dressing is applied.
Urgotul takes care of the natural healing process, protecting the wound and creating the right conditions to restore skin. For all acute wounds and epidermolysis bullosa, clean and rinse the wound according to local protocol. Pet dry the wound with a sterile gauze. Remove one side of the protective transparent film. Carefully apply the contact layer on the wound in a single layer. Cover Urgotul with a secondary dressing suitable to absorb the level of wound exudate and hold secondary dressing in place with a conforming bandage, adhesive tape, or an elasticated tubular bandage. Urgotul can be cut to fit the size of the wound. It can be meshed to pack cavity wounds. Frequency of change should be adapted to level of exudate. Urgotul should be changed every 2 to 4 days and may be left in place for up to 7 days depending on the wound condition and protocol.
Now, if you want to talk about motivation and talking about high spirits, I suggest that you visit this website. I have met this absolutely amazing person when we were at the Wounds Australia conference in Brisbane last year. What amazes me is he's always smiling. He is such a great guy. He's almost 40 years old nowadays. What was funny was that he was with us during a presentation where somebody was talking about a chronic wound that had been in place for 6 months, and he started laughing. He said, "Well, I had my wounds for the past 34 years." So he's an amazing guy. I suggest you go there. He's got videos on YouTube, even lifting those weights, which is absolutely amazing. So you know what? We take care of these patients as best as possible, but life goes on. Dean was telling us that he spends anywhere between 2 to 4 hours every single day with the help of his mother to change the dressings. And that tells you a bit about how much these patients do suffer, both psychologically and physically. Um, that's it from my side. Thank you very much for your very, very kind attention.